Maybe I'll just start with a question. So obviously we hear a lot about genetics. It looks complex. I get the impression we know a lot about it, but not all about it. So when do you think we'll start to feel and see genetics in the clinic as routine? That will just be, everything will be driven by, not everything, but genetics will play a bigger role in treatment decision making?
So I think that genetics should currently be a routine part of every patient's diagnosis. So all patients should now, after the NICE guidance, have access to FISH testing at diagnosis. So that is a simple genetic test. It's not cheap, it's not easy, but it should be accessible to everybody. And that information can inform treatment decisions now in terms of using Velcade in patients with a 414. And so I think that that is something that we should all be doing now. I think that over the course of the next 5 years, we'll be using more and more detailed genetic tests to look for more and more specific changes, and hopefully be able to use that information to tailor treatments, first as part of clinical trials, but subsequently as part of therapies as and when they become available to us.
So I guess to be commissioned in the NHS, it needs to be part of clinical trials that get a license, that go to NICE. Otherwise, you can think, well, okay, I can do a test and I can say, well, T414 Velcade, but if that's not in the algorithm, you're stuffed.
Yeah.
Okay, we've got a really good question here from Leslie. Should patients have FISH testing done at relapse if they've never had it at diagnosis? So is there merits of doing FISH downstream?
I think it would depend. So I think that some of these decisions are patient-specific. So I think the answer is always yes, but I think I would tailor that with, you have to take the patient as a whole. What are their expectations? How likely are they to have access to a clinical trial, for example, that on which this test may lead to, and how is it really going to change what you do? So I think the answer is yes for all, but with the caveats of taking an individual patient approach as well.
Okay. And does FISH testing have any role in MGUS, given the fact that all patients start with MGUS and the MGUS tends to be early stage myeloma? So should we be doing FISH testing in MGUS patients? So
there have been studies looking at the association with progression from MGUS to symptomatic myeloma based on genetic testing, so different copy number abnormalities and different translocations. I think that there are also other, if you like, simpler parameters that we use to predict risk in MGUS in terms of monitoring, so abnormal serum free light chain ratios, for example. And I would also say that a large proportion of patients with MGUS don't currently have a bone marrow, and these tests can only be done on a bone marrow sample. And again, that is something that I think I would take the patient's individual circumstance into account. So I think if I have a frail, older patient with multiple comorbidities who has a newly diagnosed MGUS, I may not wish to submit them to a bone marrow test on the basis that that is unlikely to be their life-limiting condition, whereas for a younger patient with MGUS, I would be more inclined.
Yeah. Any questions from the floor? We don't all need to take. I don't need to take all the questions from the iPad. So is anybody? Sorry, Barry, I thought you were about to just go like that. Yep.
How about amyloid? Any connections between any?
Sorry, if I just say if you want to ask a question, somebody will arrive with a microphone.
Are any patients more likely to get amyloidosis from any of the tests that you've seen?
So in terms of whether they are more likely to have amyloid, light chain amyloid deposits associated with their plasma cell clone.
Yes.
So there are some studies looking at different genetic mutations in amyloid plasma cell clones, which are similar to those that we see in myeloma, but as yet we don't have a kind of predictive way of using genetic information in that way, no.
Okay. Any more questions? So one last question from me is that from a sort of nursing patient perspective, so if I've understood your talk, is that we have to do baseline bone marrow to understand what the clone, what's going on, to determine risk or whatever. Then that will change based on your treatment. Then presumably you want to take another sample at relapse, do the same, So in a 10-year period, patients may have 3 or 4 relapses. So that involves giving bone marrows. So patients don't like bone marrows. So how do we do this from a nursing perspective, encourage patients and have patients understand that to contribute to research that's going to advance treatment and lead to better outcomes, and in routine clinical practice in the future, we're going to have to give more bone marrow. So is there any innovation? Is there any new technology, new techniques, new ways to get bone marrow? And will we always need bone marrow, or can we get liquid biopsies? Can we do it finger prick? Is there, what's coming? Because patients do not like bone marrows.
So I think at the moment, it's important to have a discussion about how myeloma disease changes over time and how that might alter a patient's treatment as a subsequent relapse, and discuss with them therefore the need to have a repeat bone marrow several times over the course of their disease. I think there are things we do badly about doing bone marrows at the moment. I think that we, as doctors or nurses who perform a bone marrow, need to think about how we are doing that, the analgesia we use, the setting we do it in, and our approach to it, I think could be dramatically improved. In the long-term future, then we will hopefully have developed liquid biopsies that we can get all of this information from. So a liquid biopsy that Eric's referring to is effectively taking a blood sample from a patient in which you will find very, very small fragments of a myeloma cell, or what used to be a myeloma cell, from which you can then do genetic analysis to identify these changes. But at the moment, that is purely a research-based test.
Oh, hurry up. Okay, we're out of time, so thank you very much again, Charlotte. Thank you.